My name's Randall Faull. I'm chairing this afternoon's meeting, and today it's a presentation from what is known as the ANZ Data Registry. That's the Australian and New Zealand Dialysis and Transplant Registry, which I can say without any fear of contradiction is one of the most outstanding clinical registries in the entire world for multiple reasons. We're very fortunate at the Royal Adelaide Hospital to have the two main clinicians who are leaders and driving forces behind this registry. The first speaker is Professor Stephen McDonald, and the second speaker is Associate Professor Phil Clayton. So I will turn over to Stephen to start his presentation, and we plan to take questions for both presenters at the end.
Fantastic. Thank you, Randall, and thank you to the organisers for this opportunity to talk a little bit about registries and in particular renal registries. I'd like to start, of course, in Reconciliation Week, especially with an acknowledgement of country and an acknowledgement of the Kaurna people whose lands we're on today, and pay my respects to their elders past and present. So I was going to spend a few moments talking about what a registry is and what ANZ Data in particular does, and then really focus a little bit on a couple of areas where we've been extending the traditional registry activities to beyond just reporting on the numbers, and in particular touch on some work we've been doing around registry-based trials and also around kidney transplantation and access for some disadvantaged groups. And then Phil is going to continue that theme around how we've been using data to really drive change in practice. So registries are one of those things that is often easier to identify than to define, but there are a couple of particular distinguishing characteristics of clinical quality registries such as ANZ Data. There are others based over, particularly at SAMRI. There's a joint replacement registry. There's a prostate cancer registry. CADOSA is an excellent registry based out of the Queen Elizabeth Hospital. But one of the things that characterises them all is a high degree of clinician engagement and completeness of data collection for their given group, although that data collection does tend to be broad rather than deep. So ANZ Data has been in existence in its present form since 1977, but has data from 1963 and has coverage of all people receiving long-term dialysis or who have received kidney transplants in Australia and New Zealand, and that data is collected from renal units. There's a number of ways in which that data is provided to various people. There's some lay or consumer-based summaries which are readily available from our website, together with an array of more in-depth reports extending to scores of pages each year of data that's often very useful for both clinicians and health service providers. And all of these are available from our website, so if you're interested, I'd encourage you to go there, look, browse through, and if there's questions that arise, you'll see links to a request process for finding out more. Of course, as a registry, there's a lot of, if you like, so-called routine stuff that we do. There's a number of safety and quality graphs and reports that we produce, both yearly quality reports looking at risk-adjusted outcomes for individual units, and this is an example from the dialysis report looking at standardised mortality rates. There's a variety of KPI programs, and the lower is a shot from a quarterly report looking at peritonitis. What hasn't come up on the graph here, unfortunately, is a map that we produced, and there's a so-called spider map illustrating the mismatch between demand and supply of dialysis services in Adelaide, and we provide this on a routine basis for various health services to assist in planning. I did, though, want to move sideways, if you like, to the role of the registries, and in particular the ANZ Data Registry as part of what is really an evidence ecosystem in the area of kidney disease. A number of years ago, in fact about 7 years ago now, in ANZ Data we formed a collaboration with the Australasian Kidney Trials Network, with the Australian Clinical Kidney Guidelines Group, CARI, and the Cochrane Kidney and Transplant Group, really to try and bring together the elements of this, this cycle of improving healthcare and using clinical quality registries closely linked with vehicles to generate evidence and create clinical guidelines. One of the themes of that was using a clinical quality registry as a base for doing pragmatic registry-based trials. So if you like, building on the strengths of a registry that is a high degree of external validity and inclusion of real-world people, together with the rigor of a randomized controlled trial to actually create evidence that could then be used to drive practice. And we've now, in fact, got 4 active registry-based trials. Best fluids in the field of transplantation is in the follow-up phase, and that's looking at plasma-light versus saline. And the other 3 trials are looking at dialysate sodium, use of a standardized curriculum for peritoneal dialysis training in the case of Teach PD, and SWIFT is looking at the effect of symptom monitoring on the quality of life. And these are all interventions that are not expensive pharmaceutical interventions. Indeed, no pharmaceutical company is going to be remotely interested in funding these, but they are all very pragmatic, very important interventions that have been facilitated by this movement to registry-based trials. The other area that I did want to dwell on for a few moments is where we've been using data to drive change in terms of access to transplantation. And one of the things that's been demonstrated for a number of years now is some striking differences in the way we provide care to different people. So if you are receiving so-called kidney replacement therapy, that is either long-term dialysis or kidney transplantation in Australia, about half of people overall have a kidney transplant. Of the other half, about a quarter are receiving some form of home-based therapy, and then the remainder are receiving a facility-based therapy, that is hemodialysis, either in a hospital or in a satellite. If you are Aboriginal or Torres Strait Islander, however, that graph looks very, very different, and the enormous difference is in fact driven by the lack of kidney transplantation. 3/4 of people are in fact receiving their care from a facility. In the background, of course, is the excess rate of kidney disease among Aboriginal people, and that's a difference that in fact isn't going away, and there's a whole another story about that for another day. What I did want to dwell on today, though, for a few minutes is some of the roles that we have had in picking apart the access to treatment. So the steps of getting to a kidney transplantation are complex, and there's a series illustrated here. There's 2 critical points at which we've been collecting data for a number of years. One is the point of placement on the transplant waiting list, and then the second is moving on to allocation, or actually receiving a kidney. And so a number of years ago, we began a process of looking at this in more detail, and the long and the short of it is that the block is not in the allocation of the kidneys once you're on the waiting list, it's getting onto the waiting list, and it's that first year or so, and you can see this striking difference here in these cumulative incidence curves. And that is not just about being Indigenous, it's also if you're older and living remotely, there's a greater disadvantage. And you can see here in this graph that there's an early difference and there's never any catch up. So one of the things that we've done is work with the Transplantation Society to not just report this, but actually do something about this. And so we led a process of formation of a so-called expert panel that identified a number of barriers and facilitators to kidney transplantation, went and met with the minister with some 35 recommendations, and that led to the establishment of the so-called National Indigenous Kidney Transplant Task Force, which we now host within ANZData over at SAMRE. And that's running, as you can see currently. There's a whole other story about this, but in brief, there's 3 main threads of work: some improvement in data collection, a number of initiatives to improve, to pilot various ways of improving access and patient equity, together with a piece of work around evaluation of cultural bias initiatives. One of the critical areas of improving patient access was actually engaging and involving consumers and catalysing the creation of Indigenous specific patient reference groups for transplanting units, something that had not been in existence prior. And you can see here various photos from the groups that are now in existence in a number of jurisdictions and driving change. So for us in this area, the next steps are firstly some evaluation in the latter part of this year of the various pilot programs together with the cultural bias interventions, and that will be feeding into what's been targeted as a national priority, that is a national Indigenous transplantation strategy, and comes together with some work that has been done by the Federal Department of Health. So look, I'd like to finish this bit by just summarising that from what I hope I've given you in just a couple of minutes is a potpourri of where registry data can be used. It's valuable in and of its own right for safety and quality purposes, for health service planning, but it can be used to drive change. But crucially, change doesn't just happen. It needs to be implemented. It needs to be implemented by people with time and also with close connections and collaborations with relevant clinical groups, with consumers and with government. I know Phil will do this as well, but I'd just like to, for a second or two, just acknowledge the team that work in ANZData, that drive all of this work, the teams in the renal units that contribute the data, and the funders of the registry, the federal government, the New Zealand Ministry of Health, Kidney Health Australia, together with those that contribute our research funding. Over to you, Phil.
Thanks very much, Stephen. So I'm just going to be talking about allocation of deceased donor kidneys. So Stephen's obviously given an overview of the registry and its operations. I'll be talking about the benefits of kidney transplantation, and then principles of deceased donor allocation, how the old system worked, how the old system in many ways didn't work, some simulations that we did of alternative systems, and then what we've ended up doing as a result of that work. So kidney transplantation compared with dialysis is associated with a number of benefits, not least of which is improved survival. This is the mortality by age for the general population in green, and on dialysis in red, you can see the mortality is up to 100 times what it is for the general population. In transplant recipients, the mortality is still higher than the general population, but is quite a lot less than on dialysis. And transplantation also improves quality of life. So this is a number of different quality of life measures in these 4 lines, from pre-transplantation over here up to 24 months post-transplant. And as you can see, for just about everything, quality of life does improve following transplantation. So you live longer and you feel better. And to top it all off, it also costs less money. So this is a slightly old study now, but estimating the cost of hospital hemodialysis around about $80,000 per year per patient. Whereas with the kidney transplant, the first year is a bit more expensive because you've got surgery and you have some induction immunosuppressive drugs and frequent visits, frequent blood tests and so on. But then from the second year onwards, the cost falls to about $12,000 a year, compared with the $80,000 for dialysis, which is ongoing every year. So it's actually quite a lot cheaper as well. So it'd be great if we could transplant just about everyone, but we can't. And one of the reasons we can't is there are not enough kidneys available for everybody. So this is the transplant rate for patients aged 15 to 64, which would be a very commonly transplantable group on dialysis. So what you're seeing here is how many transplants are performed for every 100 years that people spend on dialysis. You can see, for example, in South Australia in 2018, there were 10.1 transplants for every 100 patient years, 100 dialysis years. Overall in Australia, it's 12. So most people will not get a transplant in any given year, and many people will never get a transplant. So obviously transplantation is good. We'd like to maximize the benefits that we can get from transplantation. And one simple way to do that would be to do more transplants, either by improving our deceased donor rate or by recruiting more living kidney donors. But the other thing that we could look at is improving the allocation of kidneys from deceased donors. So when you have someone, when somebody dies and donates 1 or 2 kidneys, we need to work out who on the waiting list should get those kidneys. There's actually over 1,000 people on the waiting list in Australia. And so it's actually a somewhat difficult question to decide who should receive those kidneys. They're obviously a precious resource, and there are important considerations of utility, which is trying to get the most out of that precious resource, so have a kidney that will last the longest amount of time, but also equity, ensuring that people have fair access to transplantation. So the old Australian model, which was in place for about 20 years, had a couple of things. Firstly, in order to be on the list, you needed to have kidney failure and be on dialysis, and you needed to have a high likelihood of a significant benefit from transplantation. That's pretty straightforward. But then once you're on the list, there are these different criteria which we use. They're combined into a score using an algorithm to decide who would get the kidney or kidneys. And you can see that most of these are actually addressing equity. And the only ones that really address utility, so how well the kidney will go, essentially, or how well the patient will go, are the immune match between the donor and the recipient, which doesn't actually predict very strongly the outcome, and childhood, which makes up a very small proportion of the list. So mostly the old allocation system was built around equity. There are some better scores that can be used for utility. So this is the Kidney Donor Risk Index, which is a multivariable score predicting graft survival. It was developed in the US and we validated it using ANZ data, and we found that it performed about the same as it did in the US. It's moderately good at discriminating between different donated kidneys. And then this is the estimated post-transplant survival score, which is a patient survival score, which again is moderately good at discriminating between different patients in terms of how well they will survive following transplantation. Now, if we had a truly utilitarian system, we might expect some kind of correlation between the donor score on the y-axis and the recipient score on the x-axis, whereby the kidneys with the best prognosis would be going to the recipients with the best prognosis, and so on. But this is how the old system actually worked. There was really no correlation at all. So any kidney would pretty much go to any recipient, which is not very utilitarian. Another problem with the old system is that patients who had a lot of antibodies against potential donors had a lot of trouble getting access to transplantation. So I appreciate this is a busy slide, but if you look at the top curve here in green, this is the transplant rate year by year for patients who haven't got any antibodies. And then down the bottom in grey, this is the transplant rate for patients who have antibodies against most donors. And of course, those people are more difficult to transplant. We try to prioritise them in the system, but they're still getting quite substantially inequitable access to transplantation compared with these unsensitised patients. And patients with other levels of antibodies are in the middle. So what we set about doing was some simulations using data from ANZ data, as well as ANZOD, which is the organ donor register, which is also run by ANZ data, as well as some information from the tissue typing labs, which we linked to ANZ data about, I think about 10 years ago. So these simulations included waitlisted patients, donated organs, statistical models developed using ANZ data and allocation rules, put them into this software we'd adapted from the US, and then looked at what happened. And a couple of things, we could design systems that were more utilitarian. So from the top current system down to the bottom down here, we've got increasingly restrictive with who we're offering the best prognosis kidneys to. And as we did that, what we can predict is that the total life years of patients in the simulation, not just those who are transplanted, but also those who are missing out. Once you add them all up, the total life years can be improved compared with the current system. But we can also improve access to transplantation for the sensitized patients. So here we've got this is how many antibodies you've got. So these are the most difficult to transplant patients, and on the x-axis is a transplant rate. The current rules in blue, sorry, that's actually now the old rules, and the green rules are the green ones are the new rules. You can see that we could substantially improve transplant rates for these most highly sensitized patients, although the ones who are moderately sensitized under that system, at least, that simulation, have slightly lower transplant rates. And there's always going to be some trade-offs. So happily, having spent many years working on this, around about 4 weeks ago now, the Transplantation Society introduced essentially a new allocation system, which is designed specifically to be more utilitarian, as I just showed, but also improve access for highly sensitized patients. And also what I haven't showed you is that it improves the allocation of well-matched kidneys to young recipients who are likely to need another transplant in the future and therefore benefit from getting good matching from their first kidney. So just to summarize, kidney transplantation improves quality and quantity of life at reduced cost, but there are not enough deceased donor kidneys available for everyone. The old allocation system was not optimally utilitarian or equitable. And using these simulations from registry data, we have designed and implemented a new system which we expect will improve both utility and equity. And this is just one example of showing the power of registry data to inform policy decisions. And Stephen's already thanked most of the people that contribute to ANZ data, but here are a few other people that contributed to this work. Thanks very much.
Thanks very much, Phil and Stephen. So we can take questions, type questions from the floor. while we're waiting for some questions, I just would start by, Phil, I'd like to draw you out a bit on how you would evaluate this particular initiative. I mean, what would be the criteria you would use to measure the success or otherwise?
Yeah, so one of the interesting things about changing the allocation system is you don't know what would have happened if you hadn't changed it, or if you change it to something else. So all we can really look at, and what we are doing already, is looking at, is it working as expected? Are we giving kidneys to the people we thought we would be giving kidneys to? We've identified a number of important groups to ensure that they have equitable access to transplantation, which includes Indigenous recipients who may potentially be disadvantaged from a system that looks at immune matching because they're a minority group, as well as children and older people, and looking within blood groups and within states. And we're monitoring for unexpected side effects, such as sending too many kidneys out of South Australia into other states, which was simulated to occur, but happily the opposite has happened at the moment, but it will no doubt even out over time. And that's essentially what we're doing to start with. We need to look at what happens to the waiting list. And one of the interesting things about simulating a new system is that you have to an extent, you have to assume that people's decision about whether or not to accept an offer remains the same, but probably people will start changing their behaviour once they realise what's happening under the new system. So we'll just have to keep monitoring it closely.
Okay, thanks, Phil. So we've got a question, I think really more for you, Stephen, from, in fact, one of our colleagues, nephrology colleagues. So the question is, at the moment, ANZ data is limited to patients on dialysis who have had a kidney transplant. Is there scope and will to expand ANZ data to capture patients with renal diseases who do not need dialysis or transplantation, which might help understand the epidemiology, causation of disease, and facilitate clinical trials in this patient group?
Yeah, look, that's a good question, and it's one that is being brought up from time to time, and it does go to the core, I think, of what the intent is in setting up a clinical quality registry. And typically they are set up for procedures that are expensive and have either or are expensive or have a high risk of adverse outcomes, and those criteria do fit the area of dialysis and transplantation quite nicely. In the area perhaps of chronic kidney disease more broadly, those cases aren't as strong, and in particular the cost of caring for people with early stages of kidney disease is lower, and the need for, if you like, a focused clinical quality framework hasn't been as strong. Questions around epidemiology of disease, causation of disease, and facilitation of clinical trials are important ones, but they're ones that inherently come, I guess, out of the research world and need to, and so that if there was a clear need for, if you like, a large cohort study to examine some aspect of the natural history of chronic kidney disease, then that would be one approach. But currently, despite a number of good discussions, the tipping point hasn't been reached to justify a widespread national pre-dialysis registry. And I think it's unlikely to get up and running at a national level, although there have been some regional areas. What's more likely to happen, I think, in time, as we improve linkage between data sets, is use of in particular, pathology data sets to identify people with advanced stage kidney disease and link them through to primary care data sets and hospital medical records to examine the quality of care and rates of if you like, rates of progression of disease that way. That's an aspirational aim that requires some linkage of data sets that's probably some years away yet.
I think also, Stephen, one of the things you haven't emphasised but may be helpful for the audience is that the contributions to ANZ data are all voluntary and unfunded, paid for. So it's pushing people to put in more work, more time is a challenge.
Yeah, that's an important thing. And it also goes to who cares for groups of patients, and the registries that are highly functional generally have a very clearly defined group of data contributors. So in the case of ANZ data, it's people that are in renal units. Running such an exercise across the thousands and thousands of general practitioners around Australia will be a very much more challenging exercise. And similarly, other successful registries usually have a pretty focused data source, if you like. So the intensive care registry, the cardiothoracic surgical registry, so on, have a very highly focused data source.
So Stephen, I'll just ask you a similar question to Phil. If in this area of registry-based trials is a newish and evolving area, and in say 5 to 10 years' time, what would you see as a good measure that it's been a successful?
Yeah, so historically, one of the problems of nephrology has been an absence of high-grade evidence. So fundamentally, a lack of randomized controlled trials, and those trials that have been done have been driven, as is the case often elsewhere, essentially by the discovery of a new drug, a new device, and then that's driven by commercial exercises, commercial interests. And so I would see success as a series of trials, some of which will be positive, I hope, but you don't know. That's the reason why you do trials. But a series of trials able to examine some of the hypotheses that have been around for a while. In many cases, are clinically highly relevant, but need to be tested. And also, even if there is a negative result, that's not a problem, and it may in fact save a large amount of effort. And so one example of that might be the SWIFT trial, which is actually testing whether systematic measurement of patient-reported outcomes, so asking patients whether they have a specific set of symptoms and feeding that back to their treating team, whether doing that over and above normal care actually improves people's quality of life. And you might think, okay, well, that's a no-brainer. Surely it should do that. There are programs that are being rolled out in other jurisdictions, in fact, to do that in a systematic manner. But just asking somebody whether they feel well or not doesn't actually make them feel better. And so it's important to actually test these hypotheses, particularly if they're going to involve expenditure of a lot of resources. So success for me would be answers to a series of those questions, some of which might lead directly to improved care, others of which might lead to more efficient care by not pursuing unhelpful or not useful or potentially harmful practices.
Okay, so I believe we've come to the end of our time, Tamara. So I'm sure Phil and Stephen would be very happy for anyone to contact them directly if they have any other questions or wish to get involved. But thank you for your joining us today. And